And now I'm pleased to introduce today's speakers, Doctors Maureen Boyle and Donovan Maust. Dr. Maureen Boyle is the Chief Quality and Science Officer at the American Society of Addiction Medicine, also known as ASAM, where she oversees development of clinical guidelines and other tools to promote evidence-based addiction treatment. She is the managing editor for the fourth edition of the ASAM criteria and provides strategic oversight for its implementation tools. Dr. Boyle brings over 20 years of experience in research, public health, and health policy. She holds a PhD in neuroscience from the Washington University School of Medicine. And she completed a postdoctoral fellowship at the Allen Institute for Brain Science, as well as a Science and Technology Policy Fellowship through the American Association for the Advancement of Science. Dr. Donovan Maust is a geriatric psychiatrist and health services researcher. He is the Willard C. Blackney Jr. and Geraldine La Tendresse Blackney Research Professor of Geriatric Psychiatry at the University of Michigan Medical School. He is also a research scientist with the VA Ann Arbor Center for Clinical Management Research. His research primarily focuses on psychotropic prescribing in older adults across community and residential settings. He earned his medical degree from Johns Hopkins University and completed his clinical training at the University of Pennsylvania. And with that, I'll turn it over to Doctors Boyle and Maust.
Great. Good afternoon, everyone. First, I just wanted to say thank you so much to the US DRN for inviting us to participate in this webinar. So we actually reached out or created these connections in response to us developing this guideline and realizing that there are really major research gaps, both feeding into the guideline as well as the need for research on the implementation of this guideline as it rolls out. And so we're very excited to kind of initiate some conversations around that. But today's objective, so we're going to try to just give an overview of the guidelines. So Dr. Maust will lead that section, which really takes a very patient-centered approach to tapering of benzodiazepines when indicated. And then we'll talk a little bit about what we anticipate to be implementation challenges as the guideline rolls out, and areas for kind of high priority research gaps. Next slide. And I realize this slide is just another one that says that more simply, so we will go on. So we developed this guideline with funding from the FDA that we received close to 3 years ago. And it allowed us to pull together a group of medical and professional societies to work together because this is not really an addiction medicine issue. This is a clinical practice issue that affects many different specialties, from neurology to geriatrics, psychiatry, obstetrics and gynecology. So we worked with a great team of about 10 medical and professional societies to develop this. Next slide. And here's just a quick snapshot of the illustrious group of people who helped us develop the guideline. Next slide. And so the methodology that we applied is kind of a minor modification to the grade methodology. And it really, needed to be modified because the vast majority of recommendations in this area have virtually no evidence base. And so we really had to combine the kind of rigorous grade methodology with a consensus-based process. So that included convening a panel of national experts, managing their conflicts of interest throughout the process. That group defined the key questions for the guideline, and then we conducted a systematic literature review. In alignment with the grade process, we developed the evidence to decision tables and kind of for the areas where we had enough evidence to make recommendation statements. The committee drafted those recommendation statements and then rated them. And then that fed into the development of the full guideline, which went out for public comment. Then we reconcile those public comments, and then they go through an approval and endorsement process, both through ASAM as well as through all of those partner organizations. I should mention that in addition to the kind of standard the guideline committee, we also had a patient panel that was providing input throughout the process. So they provided input both on the systematic review and key questions, as well as on the recommendation statements and the full draft as we went along. They were a very engaged and engaged group with a lot of strong opinions about the guidelines on tapering. And the whole process took, I say 2 years, but actually it's relatively close to 3 by the time we got the guideline out, which actually came out this month in the Journal of General Internal Medicine. Next slide. So just quick disclaimer that, we're going to kind of go a little bit beyond what was talked about in the guideline. So some of the things that we'll talk about were not positions of the guideline committee or of ASAM. Next slide. And as I said, the guideline was, we released it on ASAM's website in March, but it was officially released in the Journal of General Internal Medicine just a couple of weeks ago. And we encourage everyone to download and share with your friends. Next slide. So the guideline talked about a number of issues related to benzodiazepine tapering, and it really starts with considerations of the risks and benefits for individual patients. So it doesn't talk about whether benzodiazepines are indicated for a given condition. That's really beyond the scope, and it would have been, with all of the potential conditions that benzodiazepines are used for, it would have been a massive undertaking. So it really starts with patient is already on benzodiazepines. What are the considerations for whether those medications should be continued? It takes a very strong stance on the importance of shared decision making and goes through different tapering strategies, the use of adjunctive medications as well as adjunctive psychosocial services, how to manage severe and complicated withdrawal, as well as considerations for protracted withdrawal. It talks about a number of specific populations, including those who are co-prescribed opioids, as well as those with co-occurring SUD or mental health conditions, as well as older adults and patients who are pregnant or lactating. We have a discussion of health disparities, as well as a discussion about what to do when tapering is clinically indicated and the patient is not wanting to. So next slide. And for the intended audience is really the clinicians out there that are prescribing benzodiazepines or otherwise supporting patients who are taking benzodiazepines, like pharmacists. And it does cover diverse practice settings, although we should say that is not meant to apply to palliative and end of life care. But we do talk about the potential for inpatient treatment, although we emphasize that is a relatively rare phenomenon to need inpatient treatment for benzodiazepine tapering. Next slide. All right, and I'll turn it over to Donovan for the clinical stuff.
Thanks, Maureen. So one thing that's important, particularly depending on the audience that you're talking to, is this idea of physiological dependence, which is the reason that benzos need to be tapered. But that is not the same thing as when I'm talking to an addiction medicine colleague or an addiction psychiatrist and the way that they think about dependence as like misuse, abuse, dependence as a substance use disorder. Those are very different things. And the distinction is physical dependence is a biological phenomenon that develops in response to repeated use of a medication. Patients, depending on, this is also important, the way that you talk to patients about this concept as well, because people can sort of be offended by the idea that you're suggesting that they're dependent, meaning addicted to a medication, or that second chunk, which is a substance use disorder, which is a chronic disease with functional changes to brain neurocircuitry that can affect decision making, has impact on your behaviors and your function and your societal role and your family role. So when I at Michigan talk to my colleagues in the addiction section about benzos, they immediately jump to the issue of substance use, misuse, abuse dependence. And myself as a geriatric psychiatrist, like I don't really think about benzos that way. Benzos for older adults, I think more like they're taking it as it's prescribed, they're not misusing it in any way. And in fact, the data suggests that for older adults in particular, that really is true. The vast majority of people on benzos are taking them as they're prescribed. Um, Whereas for younger adults, um, it is a little bit more complicated and there is maybe more misuse, possible use disorder going on. But again, just really the distinction between the guidelines are really primarily focused on the phenomenon of physiological dependence, which is why benzos need to be tapered. And because of that physiological dependence that develops, the number one sort of guideline takeaway is you should not, cannot abruptly discontinue them because of that physical dependence, which leads to all sorts of uncomfortable physical symptoms, including the potential for seizures when you remove or stop this chronic inhibitory signal in your brain that you've been exposed to. If you sort of take that away abruptly, electrical activity can sort of go haywire, and that isn't pleasant and can really have significant risks. So one of the challenges in developing the guidelines is, well, who is physically dependent and how do you decide what's the threshold for when physical dependence develops? And this is a place where Maureen referred to kind of gaps in evidence and the literature base. There aren't papers out there that like pinpoint this is the time that dependence develops. And so a challenge for the focus of the guideline, which was on um, tapering after long-term use, was, well, who needs to get tapered? And so the way that we kind of thought about this and kind of tried to operationalize it is with this table that we have, um, where we say, if you use less than half the days of the week, so 3 days or less, that's probably not enough consistent exposure that you have developed actual physical dependence on a benzo. And so it's likely that you would have a low likelihood of clinically significant withdrawal, probably don't need to be tapered. And then if you increase the duration of benzo use, so up to 3 months, months or more, and then you increase sort of the dose of the exposure within a week. So once you get to 4 days or more, so more than half of the days of a week, you are getting kind of higher and higher levels of chronic exposure, increasing the likelihood of significant withdrawal symptoms, and then increasing the need for a taper. Again, this is kind of the committee's best way to try to provide some kind of evidence or guidance to help clinicians think through who might need a taper, but really a place where there just is not actually a lot of high quality evidence to sort of draw the boundaries around who does or doesn't need a taper. So just a couple more things that I think are useful to talk about ahead of tapers is when I talk to groups of clinicians is there's a lot of anxiety around tapering, both on the patient's part, but also on the clinician's part. And so I think it's just useful to sort of actually show some of the evidence that the wheels don't necessarily fall off when people get tapered. So this is a study where it was people who were using benzos for insomnia. They were long-term users, so an average of 13.5 years, so over a decade on a benzo. They did a double-blind taper, so it was actually a placebo. People kept taking the benzo at bedtime, but they used placebo pills to taper the amount of benzo that they were getting. And then there was a comparison group of people who didn't want to stop their benzo treatment. They did this taper over 2 months, which by the end of our talk, hopefully you'll appreciate is probably a little bit fast. But the bottom line is actually that the people who stopped their benzo had improved performance on cognitive function compared to people who continued their benzos. That group of 34 that wanted to continue their benzo had worse anxiety, irritability, and lack of energy. And then overall, these were people prescribed for insomnia. There was no difference in the people who stopped or didn't on their sleep or their benzo withdrawal symptoms. And so it's just useful to help kind of challenge the anxiety that people have around tapering. This is another study that was done in primary care. It's one of the most recent big studies where they did clinician level randomization of and clinicians then the patients enrolled in the trial were chronic long-term users, and the intervention was essentially they coached the clinicians with that material in the box on the right. So information about benzos, risks of long-term use, reassurance that you can stop the medication, and then like a little pamphlet that they could give the patients. The clinicians were coached on this. They had a single visit with patients, and then that's the intervention condition number two. And then number three, excuse me, that's intervention number three, where they had that initial visit. Intervention two, they had the initial visit, but then they also had scheduled follow-up visits with their clinician after that first visit. And basically, bottom line is usual care, only 15% discontinued in both intervention arms, 45% discontinued after that kind of one visit where the focus was talking about their benzo. And again, there was no difference in anxiety or depression, sleep dissatisfaction, or alcohol consumption, which is the other big concern is if I stop their benzo, are they going to start drinking instead? And so again, just another piece of data to help kind of reassure people that like benzos can be tapered and people can really do okay. The one big caveat there is actually a paper that I published that came out kind of mid-guideline process. So while I'm on this committee working with colleagues on helping come up with these tapering guidelines, we did an emulation trial where we looked at benzo discontinuation and we compared outcomes in people who continued their benzo and people who stopped their benzo. So the thing to keep in mind here is we had a really, really strict definition of who was a long-term user. So they had to have coverage of more than 90% or more of days over a year. They couldn't have any gaps in coverage of more than 30 days, and they had to have a consistent dose over that entire year. That is a really strict definition. A lot of places use a definition of long-term use of more than 120 days, so like a third of the year. So we required, again, 90% or more. So a very strict definition of how we define long-term use. We then we identified everybody who met that criteria of stable baseline use. This is just among all adults in a commercial insurance database. We looked then over a 6-month period of time at who stopped their benzo over a 6-month period of time. And then we looked at outcomes using, I won't get into the details of the methods, but it's the emulation trials, which are trying to help address confounding in this type of study. And what we found, contrary to our hypothesis, is that our primary outcome was all-cause mortality. We found that mortality was higher in the people who discontinued their benzo. So it was about 2 percentage points higher mortality risk in the people who stopped their benzo. That was not what we anticipated. So how kind of did I think about those findings in the course of the work of the committee? Is that this, to my knowledge, was the first type of analysis using this type of approach, looking at kind of long-term outcomes. And so it's a finding that needs to be replicated. In the discontinuation trials that are out there, in most cases, they do look at adverse events, adverse outcomes, and don't necessarily find signals of harm. Again, usually those trials are relatively short term. They're not powered to necessarily detect a mortality difference, but to the extent that they have looked, they haven't found evidence of harms. And then a couple things that we didn't look at in the analysis is this, a huge question in any type of observational analysis is we don't know why the clinicians chose to stop benzos in these patients. And so maybe benzos were stopped in the patients who were the most high risk. The flip side is that if you think about a lot of intervention studies, oftentimes the people who participate in the intervention studies who are willing to stop their benzo with like a relatively minimal light touch are actually probably the people you're not concerned about being on the benzo. So I think point A could kind of go either way in terms of how it would influence the results. And then finally, a critical thing that we didn't look at was the pace of the taper, which as talk more about the guidelines is one thing that we really, really, really emphasized is that the pace of the taper is really important. And so we looked at, did they stop or not over 6 months, period. We didn't look at whether, did they stop over 1 month or did they stop over 6 months, which is probably very important to how the patient experiences a taper. So bottom line is in general, overall, the evidence base is that there are more harms from prescribing or at least associated with prescribing than there are from tapering or discontinuing. And then finally, still primary prevention is probably the safest course, and be careful when you start a benzo. Okay, so back to the first point of the guideline, which again is just they shouldn't be discontinued abruptly in patients who you think are probably at risk for withdrawal. And again, the way that we sort of operationalize this is with this table looking at the frequency, the dose, the duration of exposure. But this is another area where there just actually isn't a ton of evidence to really get precise with this table. So second guideline takeaway is continued benzo prescribing should be based on like an ongoing risk benefit analysis of continuing the benzo versus tapering the benzo. Again, trying to sort of quantify things, we suggested that that should happen about every 3 months. A reevaluation of whether continuing this or not is a good idea. At a minimum, when you prescribe a new prescription, you should have that conversation, and then to take advantage of your prescription drug monitoring program as part of that assessment. So how to think about risks and benefits. And so I think part of the deprescribing network and say people who work in the kind of geriatric space are maybe more sophisticated about this than maybe the average crowd in terms of thinking about the risk benefit of any given treatment and how that changes, in particular over the lifespan. And so risks and benefits continue along a continuum. And kind of one of my fundamental points, Maureen made a comment at the very beginning around the guidelines were sort of agnostic to the indication of the benzo. My point is, I think a lot of benzo prescribing out there isn't necessarily for what I would consider as a psychiatrist a good indication. It's not for severe generalized anxiety disorder that's gone through several other treatment modalities. It's not like panic disorder. It's not short-term treatment of insomnia. Rather, it's long-term treatment of insomnia. A colleague a couple years ago was talking about older patient she was caring for who was prescribed Xanax when his dog died like 30 years previously and was still on it. So there's I would argue, lots of prescribing that actually isn't really based on a good diagnosis and indication for which benzos have been studied. And so how do you even think about the risks for someone like that? Really, all the evidence has for them are the potential harms of the benzo that they're on. How imminent are the risks? If somebody who just recently had a fall, maybe you would say, okay, they're probably elevated risk of a fall from this benzo exposure. Are there other interventions? Do they have generalized anxiety again, and they haven't tried alternative pharmacotherapies? What are the risks for that individual of those other treatments? So anyways, it's a risk benefit conversation that really will be very individual for individual patients. Here's another kind of big table that was in our guidelines. I think the bottom line really from this is that this is why we repeat the phrase patient-centered a lot in the course of the guidelines, because this really is individual for individual patients. And in particular, for as people age, their risk benefit when they're 30 or 45 or 55 is not the same as it is when they're 75 or 85. Um, Kind of particular considerations we pointed out is co-prescribing of opioids. We know the increased mortality risk from co-prescribing opioids and benzos. So that should get your attention. And that actually is an area where there's sort of decent evidence. Um, uh, do they have a substance use disorder? Um, Other co-occurring physical conditions or mental health conditions. So there were just like a couple specific factors that we kind of called out. But again, bottom line is it really is patient-centered. And that includes, we wanted to be clear that the assumption should not be that benzos are tapered for everyone. I would be like, I think, kicked out of my profession of psychiatry if I didn't make that disclaimer. Like, there really are patients for whom benzos are an appropriate treatment. And so please don't, you wouldn't want people to have a take home that everyone should get tapered. Um, Collaboration with patients, again, along with patient-centered, we talk about collaboration with patients a lot. And, like the slide says, everywhere a recommendation says clinicians should consider, the phrase in partnership with the patient should be understood. This is a big area where we don't have enough evidence. So if you talk to the patient and you agree that the harms outweigh the benefits of the benzo and you would like to embark on a taper, how fast should that taper be? A lot of the old literature will have tapers over like 2 weeks, 4 weeks, maybe 2 months. Those are fast. Um, the the Dr. Kara Tannenbaum had the Empower intervention, which has kind of like a schematic of what the taper looks like, and it's completed over around 18 weeks or so. But again, that intervention, which was effective, it wasn't testing the parameters of the taper. There's something called the Ashton Manual out there, where she's sort of like a master clinician in the UK who tapered lots of patients off, who has a bunch of kind of proposed tapers. But again, really very limited data to compare what tapers should look like. So we sort of, based on the Ashton Manual, based on Empower intervention, kind of what was out there and kind of clinical expertise on the committee, the way we sort of wrote this out was proposing five taper decrements of 5 to 10% of the original baseline dose every 2 to 4 weeks. Um, we said it probably shouldn't be more than 25% over 2 weeks. And then if you're one of those people in that taper table of who's at high risk or low risk of withdrawal, if you're kind of in the top of that table where it's a relatively short period of time, limited exposure, you can probably do a more rapid taper in those folks. But this, again, is a place where there just really, really is limited evidence for what this should look like. Um, a little bit like tailoring the risk benefit conversation with patients, you should then tailor the tapering based on how patients are doing. If the likelihood of success is probably maximized by a slower taper, a taper that pauses when symptoms resume, being mindful of any sort of concurrent conditions that should be treated, and then thinking about other types of supports or interventions that a patient might benefit from. Um, the one thing there was maybe not a ton of consensus on is this issue of like switching. Should you, if a patient's prescribed a short-acting benzo, there's this idea that maybe a long-acting benzo it's easier to tolerate the taper with long-acting. The problem is sort of swapping benzos out is not entirely straightforward, and like the relative anxiolysis of a benzo or the relative hypnotic effect of a benzo, they don't always uh, what's the word? Transfer in the same way. And so it's easy to maybe overshoot or undershoot. Worst case scenario is a couple years. I went to work on the inpatient service, and there was a older gentleman who had had his benzo switched to help facilitate a taper, and probably that switch overshot just a little bit, and he fell and broke a hip. So like the horrible, most terrible nightmare scenario of what might happen. So that's why just with switching benzos, you want to be a little bit careful about that. Um, Another important part in the guidelines is that in general, what we know about the harms associated with benzos is that it's a dose response. So like for fall related injury, the overdose risk for opioid benzo co-prescribing, the higher dose is associated with higher risk of badness. So from a harm reduction perspective, folks should feel good if they're able to lower a dose, even if they don't fully complete a taper. And then finally, the guideline, the committee members wanted to emphasize there's no shame with a slow taper. And probably that maximizes the chance of success. If we define success as like stopping the benzo, it's probably more likely that that will be accomplished with a slow taper that really minimizes with withdrawal symptoms versus a fast taper. But again, a place where there's not great evidence. So maybe like a 6-month taper versus a 9-month taper versus an 18-month taper, maybe actually that's not good. And it kind of feeds into patients' concern that they really need the medication if you taper them out that gradually over that long of a time. So there might be some limits actually on how much longer is useful. These are maybe a little bit more in the weeds that we don't need to necessarily get into, but like Maureen said, we're mostly geared toward outpatient setting, but the guideline does address where patients might benefit from other settings for their taper. Potentially urine drug screens can be useful, but there are concerns with those. And then finally, as a geriatric psychiatrist, guideline 10 is definitely not in my wheelhouse, so I'll just move on from that one. Again, the place where there's the most evidence of harms of benzos is for older adults. And so probably the default is that in most cases, it would be prudent to be thinking about tapering benzos. Now, does that have to happen when they're 65 versus maybe 70 or 75? Again, for different patients, that when that needs to happen will be different. Um, and again, there might be some, somebody with severe generalized anxiety disorder who tried many, many different treatment options, has gone through psychotherapy, and like their clonazepam is the thing that really worked for them. Um, there still are probably some patients for whom, probably some older adults for whom benzo treatment is appropriate. And then back to Maureen.
Thanks, Donovan. So, I think key takeaway is we're, as we said, we're trying to emphasize that this is a patient-centered process. The tapers should not all be the same, that we should be, starting slow and adjusting based on the patient's response. Next slide. But one of the big considerations that we had, and discussed quite a bit with the committee, is the implementation of a guideline like this, right? We've seen, for example, with the CDC's opioid prescribing for pain guideline in 2016, that guidelines can have very unintended consequences, particularly when physicians and healthcare systems use guidelines like this as a reason to kind of push non-patient-centered responses, right? No one should have over, over X dose, or no one should be treated for, for more than X number of years. So, we talk quite a bit in the guideline about about these implementation considerations and what to be cautious of. But one of our main concerns is that, just with that, the one recommendation that Dr. Maust was highlighting for older adults, which, we're not the first to say it. And there's many guidelines out there kind of talking about, generally stopping benzodiazepines in older populations. But from our estimates, there's about 2 million older adults in the US who have been taking benzodiazepines for more than 120 days. So, and the healthcare system most of these prescriptions are coming in primary care, and the healthcare system is just not prepared to manage benzodiazepine tapering on this scale. One of the things that we heard most from the clinicians on the panel is that what patients need the most is a little bit of hand-holding. They need somebody who is reassuring them that things are going to be okay, that's there to listen when they're struggling and to adjust things as they're experiencing symptoms. So one of the things that prompted us to reach out to NIDA after we kind of finished the guideline was this thinking of, also in reference to Dr. Maust's study that he mentioned earlier, where we don't know if there are potential, the level of potential harms that are going to come from from tapering. And so we think that it's really important to study this as it goes out into the world. Next slide. So another thing that came up as we were developing this guideline is just the paucity of evidence. So we found no studies that were directly comparing different tapering strategies. So as Donovan said, should we, is 18 months inappropriate? Does that end up harming patients versus a year long or a 6-month taper? We have very little information to go on there. And most of the studies that are out there were evaluating adjunctive medication and educational interventions. For the adjunctive medications, most of the clinicians are saying, in general, we're trying to avoid that. We're trying to avoid kind of, polypharmacy here, and really stick with the adjusting the taper strategy to help the patient reduce benzodiazepines. Another thing to note is that the RCTs that we did have, they were all, I would say, almost universally looking at a rate of taper that was far beyond what the clinicians recommend. So, often 25% to 50% reductions, over, in 2-week increments. They had, those studies that were using the kind of fast rates had high dropout. And so, we think it's really important to, to study, to study the types of benzodiazepine tapers that clinicians are actually using and believe to be beneficial, in alignment with the guideline. And then we also noticed that there were very few studies that looked at protracted withdrawal. And this was, for the patient panel, this was a particular, sore point, I would say, is, they're trying to convince their clinicians that protracted withdrawal is real often. Their clinicians are often not believing their symptoms, and there's very little evidence to point to. So studies that go out longer and look past the point of discontinuation to see the functional outcomes for patients, including things like suicidality, which the patient panel and the kind of patient advocacy groups out there are very concerned with. And then just also to note, there was a very inconsistent reporting of adverse events. Next slide. And one thing that we think is a potential opportunity out there is the VA has had a number of initiatives, major initiatives to reduce benzodiazepine prescribing. So one focused on patients with PTSD, another focused on older adults. And the research that they have really looks at the success of these initiatives to reduce benzodiazepine prescribing, but they're not looking at patient-centered outcomes. They're not saying, how did this ultimately impact their sleep, their mental health outcomes, their functionality? How many patients ended up with protracted withdrawal symptoms? And so, something that's potentially useful would be, a retrospective analysis. VA is one of the places where you have consistent medical records. And so this may be an opportunity to, get more information from existing systems, as well as, hopefully doing some prospective stuff. Next slide. So, high level, I think only 3 of the recommendations in this guideline were not based on clinical consensus. So we had any evidence at all. Those were all low quality evidence that we were building upon. And so, we really want to encourage the field to, to develop more research, particularly research that's focused on patient-centered outcomes, and research that's looking at longer term outcomes, particularly protracted withdrawal. And I'm going to channel the patient panel, who was, as I said, they were very passionate. They feel very strongly about this, for advocating for research on things like, whether, so if you've heard of benzodiazepine-induced neurological dysfunction, this is kind of a theorized disorder, so, related to protracted withdrawal, that the patient panel feels very, strongly does exist, but there's just not evidence out there. And so kind of looking more deeply at protracted withdrawal and the, like, what is its underpinning, right? Is it, I think from their perspective, it's a neurological injury. As I mentioned before, suicidality is a big concern. They see within kind of the patient advocacy groups out there, which there are multiple patient advocacy groups that are just focused on this one issue of harms associated with benzodiazepine tapering. And the community there very strongly believes that the way that we are tapering benzodiazepines is increasing suicidality. And so they are, they're very strongly promoting this patient-centered, as slow as the patient needs to go, whether that requires microdose tapering, is where they're thinking to reduce protracted withdrawal and related suicidality. And another, one thing that they truly did not like in this guideline was the recommendation that in some cases it could be appropriate, and we do say it should be very rare, but to do phenobarbital-based tapering in an outpatient setting that's primarily used for patients with severe addiction. But the patient panel, feels very strongly that it leads to, poor long-term outcomes. And the research really just doesn't look at those outcomes. It's looking at avoidance of severe and complicated withdrawal in the short term. So, avoiding seizures, avoiding delirium. It's not looking at kind of post-inpatient outcomes. So we would strongly advocate for kind of more depth in those areas. Next slide. And just wanted to let everyone know that we have been working hard on developing a set of resources to help clinicians implement the guidelines. So ASAM has a continuing medical education webinar series. We've developed a provider pocket guide, as well as kind of short handouts for both clinicians as well as patients on benzodiazepine tapering. We have a number of kind of quick reference guides. We're in the middle of developing a patient pocket guide, a patient infographic, and some micro-learning videos that will be out soon. And really, if anybody has ideas of things that ASAM and our partners could develop to help with this implementation, we are always open to ideas. And I think that is all, and we're happy to answer questions.
Thank you so much, Doctors Boyle and Maust, for your excellent presentation. At this time, we'd like to invite your questions, so please use the Q&A icon at the bottom of your toolbar to submit your questions. To get us started off, how do you see us continuing to stimulate, the research in this area to help refine this great work and guideline work over time?
I mean, I think that's why we're here today. So, when we finished the guideline, we reached out to NIDA to say, like more research needs to happen. What are the ways to kind of, put this front of mind for researchers who are doing related things. And so, we had some conversations with them. Obviously, the kind of change in administration has shifted the what might be possible in the short term, but we still think it's possible. It's useful to highlight this for researchers who are doing related things and see if this can kind of be built in. But Donovan will probably have more to say on that.
Yeah, I mean, I was just going to add in particular, um, towards the end, Maureen mentioned this idea of benzodiazepine induced neurological dysfunction. I think that's what D is for
Yeah, yeah,
dysfunction.
yeah.
So bind, you'll see. And it's really, um, so people thinking about how might one go about identifying that in sort of observational data, because it's just really odd because so I did some work in the VA where we did a qualitative study talking to older veterans who had stopped their benzos. Um, and in general, they like didn't really recall, I think out of the 21 people, maybe one or two of them sort of recalled noteworthy withdrawal symptoms, and otherwise they were fine. But then there's also clearly people who have experienced harm from the withdrawal, and sort of reconciling those incredibly different tapering withdrawal experiences and thinking about like how to try to get at that in the data um, is just would be useful.
Yeah, and I think particularly like how to predict who's going to have a hard time so that you can kind of, put the
Yeah.
resources there.
Hi, looks like there's a question from Gabriella about switching between benzos, and kind of the evidence on that really is, I'd say there's not great evidence on that. Um, yeah, there's not great evidence on that. I think again the challenge with switching um is that you would be concerned that you're going to over sedate someone, or maybe you might even precipitate a little bit of withdrawal because you don't get the conversion quite right. um Sometimes, so there's just not a great answer to that, and there's actually not great evidence for that. Another thing that would be interesting to look at would be the success of tapers when people switch to a different agent, longer acting agent, or not, and see what happens.
Yeah. And let me just add what our panel said is the evidence that is out there for equivalency is one, there's like kind of three major different sources of information on equivalencies, and they have some pretty stark differences in terms, like kind of like twofold differences in in estimated equivalence. Um, and that those were developed by recording patient reported experience of, right? So like giving patients a certain amount and kind of saying like, does this feel like the same dose as the one that you were on before? So not exactly the most rigorous way of evaluating the equivalencies, and it shows. And so clinicians are dependent on these equivalencies tables, but they know that they're pretty terrible.
um I'll I'll jump to Gabrielle's question in the Q&A. So I am pretty certain that the 16-week taper guideline that the VA uses is basically an adapted version of the Empower guideline from Kara Tannenbaum. Um, there's been a number of different studies in the VA basically documenting that, like, yes, benzo prescribing has gone down, the prevalence of benzo prescribing in particular, the main populations of interest have been older veterans, veterans co-prescribed opioids, and veterans with PTSD. So that's what there are plenty of papers looking at that, looking at the decline, generally sort of like time series analyses looking after these big policy initiatives started. But again, not no studies like explicitly comparing approaches to tapering and like um randomizing, like, one clinic is primary care based, one clinic has the pharmacist helping them, this medical center does tapers over 4 months versus that one does them over 6 months. So Not, there isn't evidence in a way that was super helpful to inform the guidelines.
Another question from our audience is there a particular benzo better for tapering than others?
That again, again, is a place where there's not great evidence. That's usually why people think about switching, is this idea that a long-acting benzo works better for a taper. In general, like again, thinking about the Empower intervention, very few of those patients switched their benzo before finishing the taper. Um, the VSON study that I showed you with the 3 different arms, relatively few people switched their benzo. So probably the simplest answer is try to not switch unless there's like a really compelling reason or there's a point in the process where you really think that they would benefit from a longer acting benzo. But again, a place where there's not a lot of data. Mike, to your question in the chat about psychological dependence versus physical dependence, I think that's a place where, you know, you would try to have a conversation with those individuals around the potential risks and benefits. And then, you know, you would treat them like that, the top row of the table where um, this individual would almost certainly be in the top row where their risk of withdrawal would be very low. But probably it would be important for them psychologically to taper. One of the things that's really nice about the Ashton manual is she kind of talks about she has pearls or kind of principles for the tapering process, and how a big part of it psychologically is the patient um, coming to believe that they can function without the benzo. And so that is part of what's happening during the tapering process, and part of the hand holding that Maureen was talking about, of sort of supporting the patient psychologically to believe that they can function without the benzo. And so in that sense, that really would be the goal of a taper with somebody who's psychologically dependent, is just helping them um, accommodate to the idea that in fact they can, you know, if they're using it 2 nights a week, um, that means most of the nights of the week they don't need it. And so you're helping kind of coach them um, through the process is kind of I don't know. I don't think the psychological dependence specifically is something that came up in the guideline, but I think that's probably how most of the committee would have thought about it.
We have another
Maureen,
question.
do you have, I was going to,
Sorry.
for the other comment in the chat, do you have any thoughts on that?
I mean, you know, no, I think that covers it. I would just say, like, there is a section of the guideline that talks about patients who have like substance use disorder, but I don't think, but you know, who, you know, may otherwise have kind of a combination of physical and psychological dependence, and we kind of, you know, refer to SUD treatment, but I don't think that's really the question they were after.
Oh, sorry. In the chat, I'll just read Mike's
Oh,
question because I don't know if everyone can see it. So he said, what generalizable lessons did you learn for other groups interested in developing deprescribing and tapering guidelines for other agents, special challenges
yeah.
or opportunities to consider? What are your thoughts on that?
Yeah, I would, you know, I think for one, just one note from the patient panel. So we're working on developing some patient-facing information, and one thing that keeps coming up in there is SSRIs. And you know, and their concern about switching people to SSRIs because of the challenges of tapering those, and you know, so you know, I think that could be an area where there may be some future interest. You know, I think one of the things that we learned, like that I think was very beneficial to this process, was having so many different specialties involved, and it was very interesting to see how different specialties think about and sometimes think very differently about similar clinical processes. And so I think that, you know, like the the debate and resolution of those, I think, really strengthened the document. And then beyond that, I think, the patient-centeredness, right? That, like, when you're talking about any type of agent that you need to taper, there's going to be kind of patient fear. And how do you take that into the process and make sure that we're alleviating their anxiety about it to the extent that we can to help them get through the process.
And there's a question from South Korea asking about practical way to reduce a dose by 5 or 10% when standard tablet strengths don't allow increments like that. That's a great question, and there's not a great answer. And so people will talk about sort of like micro dosing, where they'll like scrape off. So it's like you kind of have to figure out, what's the smallest tablet available, or this, like, what form does it come in? What's the smallest amount, and how practically or reasonably, can you quarter that? Is that possible? And then if not, it's sort of, you kind of have to become good friends with the pharmacist, basically, to figure out like in what ways can you get like a liquid formulation? What can you do when you get sort of to the end of a taper and you're getting into really kind of small doses? And then I think that's probably at that point in a taper where you're getting into super tiny amounts, you're probably starting to move into Mike's comment around the psychological dependence, where that probably, as much as any physiological effects, is really sort of what you're dealing with. So like, how small is small enough, and at what point can you just be comfortable? If you can't split it anymore, you go to every other day and then every third day. But mainly you want to work with your pharmacist if they're available.
And I know that there were some studies that came out after that, maybe are not implementable right now, but kind of a placebo, like using placebo in order to, do some of that dose reduction. Interesting studies, but not something that most clinicians can do at this point.
Yeah. And then for the last question in the chat, about rehab centers for substance abuse, but not for prescribed medication, which is, true. I think it would be, that's something we talked about some, and what's the appropriate setting for treatment. If this is a person who, for whatever reason, you're concerned about for outpatient treatment, do they need inpatient treatment? Can you get them inpatient treatment? But also, the length of tapers that we're talking about, it's unlikely that someone, even if you could get insurance to pay for it, somebody probably doesn't want to be in an inpatient setting for like 4 months or 6 months. So I think that's kind of the challenge of not doing this in the outpatient setting. If, Maureen, you have anything else?
Yeah, I mean, it was something that the committee talked about quite a bit because, people with substance use disorder and people with mental health conditions have access to like a full continuum of care. We have kind of more intensive outpatient with other services or residential care that's obviously not available to others. But we think, probably many of them have mental health concerns going on, and maybe that's the reason why the benzos were prescribed. But it does leave kind of this big gap for patients who don't. It's like either straight outpatient or inpatient, which, for patient, an inpatient is just not going to take the vast majority of patients.
All right. Thank you both so much, and thank you all to our attendees for attending our webinar today. The recording will be posted on the UST Prescribing Research Network's website in the next couple of days. Our next webinar will be in the fall, and we'll have an announcements for the content and the speakers soon. Please complete the after webinar survey that will be sent to you after the close. And thank you again, and have a great rest of your day.
Thank you all.
Yeah, thank you.